So just some housekeeping. I have no conflicts to declare. I am affiliated with no products, and I won't be discussing any brands. Next. Diverticulosis. We're all pretty familiar with this disease. Here's what it looks like from the inside. Next. The colonic mesentery usually enters at the posterior tenium, and the diverticuli usually form between the two lateral tenia and the mesenteric tenium. And that's at the site of the vascular penetration commonly. Leaves a defect in the muscular wall, so it's essentially a herniation of the mucosa through the defect, except for right-sided diverticuli, which is probably a specific genetic trait. Next. Very, very common in our half of the world, but described as long ago as late 1700s by Littré. And in as early as the approximately 1870, it was suggested that constipation might well be the cause of it. Diverticulitis itself was not actually described until just before the turn of the century in 1899. And in 1907, Mayo, not the clinic, the man, suggested surgical management of the disease, but also suggested it should be rarely required. Next. Back in the 20s, autopsy studies, begun in the 20s, demonstrated that the overall incidence was then 2 to 10%, but it did rise to about 65% by age 80. About 20 to 25% now, but statistically 10 to 25% of those people will go on eventually to develop diverticulitis. There's no gender differential and a little local connection. The concept that bleeding occurs more commonly in men but stricture in women is a Phoenix concept by Dr. McConnell. Next. But our incidence is increasing. Hard to show some of this in the United States because it's harder to do this kind of research. But in Finland, where they keep rigid records of their population, there's been a 50% increase in diverticulitis over the past 2 decades. The incidence in the non-Western world is also increasing as a Western diet is adopted. In Africa specifically, and particularly South Africa, where this has been well studied, the incidence of diverticulosis, but not of colon cancer, rises with the urbanization of the rural populations. Next. So low fiber diet was suggested as a cause back in 1971 by Painter and Burkett. It's very difficult to directly prove a causation here, but there's a large volume of accumulated data now that supports a high fiber diet as being beneficial. So to make it short, next. This is a bad diet, next, and that's a good diet. So if you missed the salad bar today, go back. No, not to the slide, go back to the salad bar. So why does fiber help? It's thought, it's thought that fiber appears to decrease the incidence, and as I said, causation is difficult to prove, but why? Well, we know that increased fiber will increase the bulk, the weight, and the frequency of stool, but it's not immediately clear why that would be a beneficial thing, and that's what's hard to prove. But we can show that a low fiber diet will increase the peak pressures and amplitude in what are called segmentations by as much as 9 times. Segmentations are an effect where areas of the colon will contract while one relaxes, and it creates a little pocket. It acts like a little grinder, and it facilitates the absorption of the water. Brand consumption will then reverse this, and this has been measured. Next. But what about elastin? Well, diverticular disease leads to the thickened circular muscle that we have all seen, and a shortened tinea and a narrowed lumen. However, that muscular thickening, which most people think is hypertrophy of the muscle, is not hypertrophy of the muscle. It's due to elastin deposition. Diverticular disease tinea will have up to 200% increase in elastin, according to Whiteway and Morrison, and this will lead to shortening and that classic accordion effect of the colon. Next. Maybe it's collagen. Well, the increased collagen cross-linking definitely occurs normally as we see aging, and diverticular disease increases as we see aging. And we do know that diverticular disease patients show a marked increase in collagen cross-linking. This is similar to what we see in Marfan's and Ehlers-Danlos patients, and they also show early diverticular disease. Next. But it's probably just all about inflammation, and there is data that suggests that inflammation plays a role in the early development of diverticular disease. In fact, inflammation can be demonstrated before any diverticulitis has occurred. Furthermore, anti-inflammatory medications like 5-ASA and mesalazine will decrease diverticular disease. Next. There are some factors that have been suggested, but all disproven. Smoking, alcohol do not increase. High-fat diet, nope, just heart disease. Caffeine, thank goodness, no effect. What is supported is that obesity itself is a direct link to diverticular disease, and so does lack of exercise without obesity. Next. In this country, we have 312,000 admissions annually, 1.5 million hospital inpatient days, and $2.5 billion are spent on diverticulitis. Uncomplicated diverticulitis we see almost every day that we're on call for acute care surgery, and nowadays most trauma surgeons get to do double duty. You see here in this picture an inflamed sigmoid colon. Next. But with uncomplicated diverticular disease, the treatment is mainly medical. Antibiotics, fluids, gut rest, highly questionable, by the way, pain control, and then after recovery, colonoscopy at about 6 weeks. So jumping back just for a minute to that gut rest thing, that's standard here in the United States. First thing we do is put patients to gut rest. There's increasing evidence, particularly out of Europe, that shows there's absolutely no benefit to gut rest. So let's move to complicated acute diverticulitis. Here's a patient with that classic accordioned, if you want to go with the true technical name, they call it orchestralization. That's too big for me to say, so you only get it once, of the sigmoid colon. Next. This patient has, as you can see anteriorly, a loculated abscess with some free air adjacent to the inflamed colon. Next. Here's another complicated case. This patient obviously has a little tiny bit of free air. Just, you see it right there above the liver. Next. This patient here has not only free air, but the whole right pelvis over there, that's not in the bowel, that's free contrast and fluid, as well as the free air that you can see just above the inflamed colon. Next. So what do we do about complicated diverticulitis? Firstly, we have to consider the patient's condition and then also the disease severity. CAT scan is the best current guide to management. We have to decide, is the patient perforated or do they just have severe inflammation? Hinchy stage ends up being pretty critical to what you decide to do. But beware of immunosuppressed patients because they'll present to you very sick but not that tender, and they'll get away from you before you get on top of it if you think you can sit on them because they're not that sick. Next. So Henoch Classification, we divide them in the simplest form to Henoch 1 through 4. And a Henoch 1 is a localized process with a localized pericolic abscess. Henoch 2 requires you to have a large mesenteric abscess or retroperitoneal abscess that's large. 3 requires essentially a free perforation and peritonitis. And Henoch 4 is what we call fecal or feculent peritonitis. Next. So here's a picture of a Henoch 1. This patient has had that omentum that's in the surgeon's right paw there peeled away, displaying what had been a essentially sealed perforation. You might ask why they're in the OR, but they're there anyway. Next. Henoch 2, this is also peeled away. The colon has been peeled down from the lateral pelvic sidewall, and we have a pocket of pus here, so this is a localized pocket of pus. There's not pus all in the abdomen. Next. So here's a patient that actually has peritonitis. You can see the abscess down there inferiorly, but you can also see the yellowish peritoneal fluid throughout. You'll see these pictures again in a minute. Next. This is what you don't want to see. Here's true feculent peritonitis. This is obviously a bad form. This patient's belly is just swimming in free poo. Sometimes you just have small localized chunks, but feculent peritonitis is feculent peritonitis, and it should be factored into what you do next. So what about the treatment? Many of these people can be treated with just antibiotics. We add percutaneous drainage for a well-defined abscess. If they fail to improve, reassess them, get another CAT scan, make a different plan if you need to. Free air almost always requires surgery, but it does not necessarily require a laparotomy. And an acute abdomen, I put likely in there because someone's going to say, well, I had a patient, requires surgery. Next. So let's look at a couple of case examples. First, this is going to be a 68-year-old who presented with a 12-hour history of crampy suprapubic pain. White count was 17. Temperature is 38 and a half. Abdomen to examine was actually soft, but there was lower abdominal tenderness. CT, which you'll see in a minute, shows a localized abscess. Patient was begun on intravenous levaquin and flagyl. Next. So here's the pericolonic abscess. You can see it. I don't really have a pointer. I'm pointing at my screen. But you can see that pretty clearly. There's a little air within it. A nice clear access to the abdominal wall for the interventional radiologist. This is going to be pretty easy to drain. In this country, we drain these almost if we can see them. Another new evolving trend in Europe is not to drain these, and many of them do just fine without drainage and the abscess resolves, as long as it's not over a certain size. Next. So this patient was admitted to the floor, begun on IV antibiotics. We chose levaquin and flagyl for ease of conversion to outpatient therapy. Fluids, we stuck to the old school MPO, even though I already told you there's no data to say it helps, and scheduled the patient for IR drainage. She was discharged on post-op day 4 on PO, levaquin and flagyl, and I like to do early office follow-up because some of these people look like they're getting better and then they relapse, so we saw her 4 days later. Next. She did fine. So here's a patient that we saw before with massive free air. Next. Here's another patient with free air, but this is loculated free air, and you may not even be able to see it. Where the red arrow is, there are 3 kind of small little foci of air just trapped against the abdominal wall. Next. So if there's massive free air, the process is clearly not contained, and I don't think too many people would recommend sitting on that patient. Loculated free air, however, usually indicates that there's a diffuse inflammatory process that's causing that loculation, and it probably is a sicker patient than the patient with free air, with the single exception of a pericolic isolated loculated collection, which is a different beast altogether. So in the first free air, massive free air category, this patient's defenses haven't really marshaled yet. But in the case of the patient with what looks like loculated free air, their defenses have been unable to control this process. Delaying until there's sepsis and or SIRS greatly increases the morbidity and mortality. So a brief delay may be necessary to stabilize patient hemodynamically, but no other delay should be considered next. Next case example is JR. This is a 53-year-old who presented with 2 days of pain and fever, white count just under 20, temperature just over 39. Diffuse tenderness was noted with guarding and rebound in the left lower abdomen. CT shows free air and fluid, and this patient was started on Zosyn primarily because I just like the drug better, but it's not very easy to convert to IV stuff. So just as a disclosure, this is not JR's x-ray. I noticed while I was sitting here that I had not removed the identifiers. So this is a surrogate x-ray that's kind of similar to his. He has free fluid, he has an abscess, he has free loculated air. Next. So what's the treatment? The original treatment for this kind of problem would have been a diverting colostomy, the so-called 3-stage approach. And that was the procedure of choice for many decades. However, it leaves a diseased colon in place and feces within that diseased colon. It has a higher mortality in some studies than actually resecting it does. And at least 25 up to 50% of these never get closed if you give them a diverting colostomy by themselves. Current opinion in the US is that it should be done rarely. Next. So that's just mostly for historic reasons. So the 3 things we really choose between are exploration with a Hartmann's procedure, Now this again leaves an ostomy, so that requires a second operative procedure. Exploration with primary resection and anastomosis. This is great because you don't have to come back and do another surgery, but there's anastomosis, so there's a risk of leak and potential sepsis. And finally, the newest kid on the block is laparoscopic lavage and drainage. This may allow a safer delayed primary one-stage procedure. So Hartmann's procedure was initially described by Henri Hartmann, a Frenchman, in 1921. It was originally an alternative to APR. He found the mortality rate to APR to be about 40% in his patients, and he thought that was high. So he invented this operation, and he described it as just as easy as taking out a cold appendix. The French like to simplify things. Currently, however, it's primarily used for diverticulitis, and a second commonest reason is probably perforated carcinomas. The good thing, probably the best thing about it, is that all trained surgeons have the ability to do this operation and should be able to do it well next. It's a safe, reasonable approach. It does remove that diseased bowel, and it offers you the opportunity to wash them out. There's no anastomosis, so you don't have to worry about leak and secondary sepsis. However, it does require an additional surgery to restore the patient's continuity, and more surgery equals more M&M. So the mortality rate is at least 1 to 2%, and the morbidity rate at least 7 to 30%, according to Belmont, for that second operation. And a third of these people are never reconnected. So primary resection was suggested by Madden and Tanner in '61, and everyone pretended they were crazy and ignored them for about 20 years. But they continued to do it and publish some papers. The issues were that you have an unprepped colon, there's acute inflammation, there's infection, and there's poor nutrition. So it didn't make sense to do it. However, next. The unprepped colon issue is mainly dogma. Evidence that there is, and there's increasingly a lot, shows no difference in the outcome whether the colon is prepped or not prepped. The data establishing mechanical prep many, many years ago showed only a lower wound infection rate. It didn't show any other difference. And even that requires prophylactic antibiotics, according to Irving and Scrimgeour. So there's probably no advantage except for that none of us like playing around in feces. If that's your case, then an on-table prep is easily accomplished and not that difficult. Next. So primary anastomosis was looked at by Henoch in '96, and they looked at 113 diverticulitis cases without a single leak. Now these are probably selected patients, so you have to take that with a grain of salt. But many studies since have confirmed an equal or lower morbidity and mortality for resection and anastomosis compared to Hartmann. It does avoid the added risk of additional surgeries, and it avoids the patient having an ostomy for the rest of their life in 1/3 of cases. Safe to limit this to Hinchey 1 and Hinchey 2 cases, and probably early Hinchey 3s. Most people would not extend it to the bad Hinchey 3s or Hinchey 4s, although there are papers for doing both of those types of cases. My personal feeling is it's probably inappropriate for extensive peritonitis, at least in the acute setting. And yes, it's great when it works out, but I think the chance of a leak probably puts the patient at too much risk. Next. So what about the rationale for washing them out? When we go in at laparotomy, many of these perforations are actually sealed or actively sealing when we go in. And really the acute issue we're there to deal with is the peritoneal soilage and not so much the hole. Many of these perforations are in fact now treated non-operatively, right? We have a patient of perforation that sealed itself. We do percutaneous drainage. We give them antibiotics. We give them gut rest. And the drain may create a controlled fistula. We can deal with that later. Next. So laparoscopic lavage was described first, or at least the first that I've seen of it, in 1996 by the Irish surgeon O'Sullivan, no relation to Gilbert's buddy. He published early results on 8 patients, and they had no treatment failures and no deaths in their huge number of 8. So risk reported in 1998 out of France an additional 10 cases. They added bioglue, and they got the same results. So I don't know the bioglue added much, but they did it. In 2012, O'Sullivan revisited this, and he presented the Irish experience since their 1996 paper. So Ireland's a small place, and things kind of spread quickly, so it's a pretty common approach used there now. They looked at almost 2,500 patients, and out of that 426 patients were chosen for lavage. The lavage versus Hartman's results are there. The mortality favored lavage 4% to 10%, morbidity 14 to 25%, and length of stay 10 days to 20 next. So here's JR, 2 days of pain as we described, and here you see he's got an abscess forming down there. He's got a perforation that's partially sealed by omentum next. So the first thing that's done is to clean up the mess, wash the patient out, irrigate with saline, peel away the omentum if it's not completely sealed, and then there are some people that will try to stitch it if you can see it. Some people say that that just causes a bigger hole and not to do it next. A Blake drain is placed. I use a Blake because I don't like the little holes that can get plugged on a JP, but you can use whatever drain you want. The Blake is the one of the channels, so it just kind of runs down. I think they're easier to strip and harder to plug. But the Blake drain is placed in the pelvis, and it should be near where the process is, but not directly adjacent next. It's left dependently and near the perforation, as I said, but direct placement on the perforation leads to erosion and fistula, so I like to have a little bit of space between it. There's not a set irrigation volume to use. You wash them until they're clear. The inability to remove large fecal pieces probably means you should open them up and wash them out better. Where's Chamberlain? Did he leave? Oh, there you are. Okay, here we go. You can leave a Foley to facilitate re-entry into the abdomen for repeat lavage. This establishes a safe space so you can insufflate the patient and introduce your scope. And after at least the third and possibly sometimes the second washout, however, it's too sticky to really do much good. So I've never gone back for a fourth washout, but I have gone back for a third. Next. So JR was taken to the operating room the night of admission for a laparoscopic lavage. Post-op day 2, his white count had dropped to 11. Remember, it was just under 20. Temperature essentially normal. His pain was minimal. Post-operative day 3, he was taking clears, and he was discharged on post-operative day 5. The drain was removed in the office at post-operative day 10. The actual amount of time you leave the drain depends on how long there's drainage. And some of these people, you're going to create a fistula by doing this. He had elective resection at 23 weeks. Next. So in summary, diverticular disease is a very common problem for the acute care surgeon to deal with. Many of these patients present fairly early in the disease course. They can be best managed so-called conservatively, and we don't have to get all jiggy with it. But delay in treatment of severe cases can lead to remote abscesses, liver abscesses, SIRS, sepsis, and in severe cases, even death. Avoiding a multi-stage treatment may decrease the morbidity and mortality. Next. But there's no cookie-cutter best option. Patient's condition and the surgeon's comfort should be considered. Remember that a Hartman's procedure is a well-established, well-respected operation and will probably stay the main weapon in our bag for a while to come. But we can individualize the treatment. We can reassess our approach if the patient's not progressing as expected. And the thing to remember about laparoscopic washout is the data is just now beginning to accrue. More centers are using it in the United States, and there are a bunch of articles coming out of Texas now. Looks promising, but it's still early to get too tied up in it.